So journey to the center of the heart. The journey of any peripheral, coronary, or even structural intervention starts with gaining access. So our journey started with a 59-year-old gentleman known to be diabetic and hypertensive with previous history of long-standing bilateral lower limb edema, presenting to ER with repeated attacks of syncope. His ECG revealed Mobitz type 2 EV block with 3-to-1 conduction and a very slow heart rate, 30 beats per minute. His echocardiography was normal, apart from dilated inferior vena cava. So we have decided to insert a temporary pacemaker wire for this patient. After gaining internal jugular venous access, every time we directed the pacing wire towards the right ventricle, it take an abnormal course downwards towards the abdomen. And we repeated this maneuver every time, and it went to the abdomen. So for the sake of time, I have changed it into a femoral axis and successfully insert the pacing wire through the femoral venous axis. But to figure out what is going on, I have decided to inject a 10 cc of diluted contrast through the internal jugular venous axis, and here what we get. A dilated venous structure that drain downwards into the abdomen with nothing entering the cardiac shadow. So what is this? Let's go back to our normal anatomy. Apparently this structure is a dilated azygos vein draining the innominate vein. But why nothing entering the cardiac shadow? We did CT chest with contrast, and here is the 3D reconstruction imaging, showing that both innominate vein drain into a dilated azygos vein that went down to the abdomen and drain into a dilated inferior vena cava. And apparently this patient has bilateral absent superior vena cava, and the whole venous drainage of the body went back to the heart through the inferior vena cava. Now we understand why this patient has long-standing lower limb edema, and why he has a dilated IVC in his echocardiogram. And we understood why the pacemaker wire every time went to the abdomen and nothing entered the heart. So back to the main problem. This patient needs a permanent pacemaker. How to insert a permanent pacemaker in this difficult anatomy? We left with two options, either a leadless micro pacemaker, not available in my center at that time, or epicardial pacing through a limited lower thoracotomy incision, and that's what we did. So a quick review of literature. Absent superior vena cava is a very rare congenital heart disease, representing less than 0.1%, and almost always accompanied by persistent left superior vena cava. 1/3 of these patients present with rhythm abnormality, and this anomaly accidentally discovered while attempting inserting pacemaker wire, like in our case, or even in more complex cases, accidentally discovered while attempting venous cannulation during cardiac pulmonary bypass. But absent both superior vena cava is extremely rare, with only 2 reported adult cases, and this one is a 30 case. So although this is not a pure or a true interventional peripheral case, but we have some lessons from this case. First one, know your anatomy. Because if you don't know the normal anatomy, you will not identify abnormal anatomy like in our case. Second lesson, be ready for a challenging anatomy and roam the unknown as we did. Third one, out-of-box solutions for unusual scenario, and here intervention innovations come. And finally, thank you.
Excellent case. Certainly that can be very challenging, especially in the middle of the night. You know, you had just woken up to get called for this temporary pacing wire. I think you did an excellent job. Indeed, a very rare consequence. And sometimes we get called to do these cases, especially in patients that have had, for example, a heart transplant, and you're trying to do a temp wire or a swan through the IJ, and you can't get access. I think it's important to be able to think on your feet, as you did, and look for alternative access points.
Thank you.
Any comments from the panel?
What happened to the patient? Did you end up putting a leadless pacemaker?
Yes, he's doing fine after inserting the epicardial pacemaker. No syncope anymore, but still complaining of the lower limb edema. Slightly improved with diuretic, but still presents.
Okay.
It looks like that venogram that you did was very helpful to reconcile the abnormal anatomy, and I think it's a great lesson that when things aren't making sense, you know, we do run into anatomic abnormalities with some regularity, not as dramatic as this, but it's always better to get more information before you start pushing harder, because that's when you have
Yes.
complications. So it's great to get the venogram. That was very helpful.
Thank you.